Yes? Okay. We'll talk about some atrial arrhythmias. The first one is called the wandering atrial pacemaker. And normally the SA node will initiate the conduction through the atria and give us our normal looking P wave. But sometimes there's other areas in the atria that'll start an impulse. So it says the pacemaker site shifts back and forth between the sinus node and other atrial sites, sometimes even the AV node. And what you'll notice is that the P waves will look different from each other. This can be caused by an inhibitory vagal effect of respiration on the SA node and AV junction. It could be normal in children and older adults, as well as conditioned athletes. So check out the P waves that you see. This one looks a little more peaked, this one's smaller, this one's a little bit biphasic, inverted. So why would you have P waves that look different from each other? Why is it some of them look normal and some of them look different? Yeah, it's switching from an abnormal site, starting the P wave, versus the SA node starting the P wave. All right, so that's it with abnormal looking P waves. And now we go to premature atrial complex. Do you ever notice if you have too many cups of coffee, it feels like you have palpitations, heart palpitations? What's happening is the heart is overstimulated and you'll have a premature contraction. It's called a PAC. It's an early impulse that originates in an ectopic location in the atria. So it's not the SA node, but somewhere in the atria, it'll originate an impulse. So you get enhanced automaticity from caffeine, from tobacco. Alcohol can do it. Anxiety can do it. Even fatigue can cause this to happen. All right, so when you get this premature impulse, let me show you a picture before we talk about compensatory or non-compensatory. It says, find the premature atrial contraction. So start at the left and go through and see if you can find it. Pay no attention to the red arrow. Okay, so P, QRST, that looks normal, this looks normal, and then all of a sudden, as soon as the T wave is over, you've got another complex started. So that would be your premature atrial contraction, and then of course it conducts and gives you a full contraction of the heart. And then the last bullet on the previous slide talks about a pause, a compensatory versus non-compensatory pause. So you see a pause in any conduction, and then it starts over as normal. Sometimes you see a pause and sometimes you don't. It's not a big issue. All right, and then we move to supraventricular tachycardia. And supraventricular means above the ventricles. So there's a fast heart rate that's being initiated somewhere above the ventricles, but we can't tell where it's coming from because the rhythm is so fast. So it's a general term. It's a fast rhythm. We know it's from somewhere above the ventricles. So we just say SVT or supraventricular tachycardia. The rate is going to be between 160 and 250 beats per minute. So that's too fast to come from the SA node. So we know it didn't come from the SA node. So somewhere else in the atria or even near the AV node, there's an irritable area initiating additional impulses. The P waves will be hidden underneath the T wave. So you're not even going to see P waves. They're there, but you're not going to see them. So you'll be unable to evaluate the P wave or the PR interval. So under this blanket term, supraventricular tachycardia, there's other names, atrial tachycardia, and then PAT. Let's see if it gives you descriptions of those. No, first it shows you a picture. All right, it says that the rate is extremely fast. So it's showing us more than 6 seconds. Do you know how you can figure out the heart rate if we don't know if this is 6 seconds? Or if we don't want to count our 30 boxes?
The boxes in
Yeah, so the little boxes between the R waves, count the little ones and divide that into 1,500. Or look for the big boxes. So if there's an R wave on this heavy red line, and then there's another one on this heavy red line, we know that the rate is 300 per minute. If there's one here, skip a line, and then there's another one here, we know the rate is 150 per minute. So 300, 150, 100. So this is between 150 and 300. What's in the middle? 75, so about 225. So this rate is about 225 per minute. Does anybody have a calculator? Let me count the little
I got
boxes.
215.
215?
Yeah.
Did you divide 1,500 by 7?
Yeah. So 214.
So you rounded off to 214?
Yeah.
Okay. So the heart rate is 214 beats per minute. That's really fast. It's you have questions, Brandon?
If the rate is above 250, would it still be considered an SVT?
Yes. Can it go faster than 250? I guess with maybe babies. All right, so really fast heart rate. Do you see any P waves? Can't see them. And then another key when you're looking at EKG strips, if you see an upward deflection between the R waves and you're wondering, is that a T wave? Is that a P wave? You'll always see a T wave for sure. So if there's just one, you're seeing the T wave. So there's no P waves visible. The QRS looks normal. It's 2 to 3 of the little boxes. And it's just really fast. So we know it didn't come from the SA node because then the fastest the SA node can initiate impulses is about 160 per minute. So we know it didn't come from the SA node. It's a really fast rate. Therefore, we're going to call it a supraventricular tachycardia. All right, so the different types. With atrial tachycardia, the rate is 160 to 250. The impulse originates from an ectopic focus in the atrium. Do you know what that means? It's outside of the SA node.
It's in the atrium.
It's in the atrium, but it's not the SA node. And it's initiating impulses. Okay, so that's what it means by an ectopic focus. Something other than the SA node is initiating impulses. The P waves are hidden. Okay, so knowing that and SVT, is there really anything different between them? It's all the same, isn't it?
Yeah.
So to me, you could use these two words interchangeably. An atrial tachycardia and an SVT is the same thing. All right, now I want to tell you about PAT, or paroxysmal atrial tachycardia. Paroxysmal means sudden onset. The word paroxysmal means sudden onset. So you'll see a normal rhythm, and then all of a sudden, on the monitor, you'll see a really fast heart rate. It could be a short burst, or it could be sustained, where it's fast maybe for 10 seconds, and then it goes back to normal. So everything looks normal, it's just really fast. Paroxysmal atrial tachycardia. All right, this is showing P waves. So it's a fast rhythm between 150, 250, but this one maybe it's showing P waves. Okay, what is an ectopic focus? This you already wrote down.
Somewhere is
Irritable area that initiates impulses. So causes of a really fast heart rate could be sick sinus syndrome. There's something wrong with the SA node. There could be cardiac disorders such as infarcted tissue. Cardiomyopathy is heart failure. Congenital anomalies where there's something wrong with the conduction system. Wolff-Parkinson-White Syndrome is a little common. You'll probably hear about it, more so in the kids. The kids will have a really fast heart rate. And what they found is the way that the conduction system is working is an impulse will start at the SA node, go through the conducting tissue to the AV node, and somehow go back up to the SA node and re-stimulate the SA node again. And then the conduction will come down and it'll re-stimulate, and it just keeps doing this, and they have a really fast heart rate. So they actually have to go in and somehow sever the conduction system, that's the part of the conduction system that's doing that, that's traveling back out from the AV node back to the SA node, and like obliterate it to stop that from happening. So you'll see kids get admitted for Wolff-Parkinson-White Syndrome, and that's how they have to take care of it. So like just burn that piece of conduction tissue to stop that re-entry circuit. So heart disease, hypertension, cor pulmonale. Instead of trying to memorize a bunch of words to go with an anomaly, do you see some commonalities here that can help you remember stuff? So anything having to do with heart failure, the word cardiomyopathy, valvular heart disease, hypertension, cor pulmonale, that's right heart failure. MI, it's all things going wrong with the heart, can lead to SVT. Trying to make it easy so you don't have to memorize a bunch of stuff. Drugs can cause SVT with digoxin toxicity. It's probably the most common cause for seeing SVT. And if somebody has hyperthyroidism, that causes a really fast heart rate also. All right, so how do you treat really fast heart rates? All right, so there's stable SVT and unstable SVT. For stable SVT, of course, the person has a really fast heart rate, but they're not symptomatic as far as chest pain, low blood pressure, altered mental status. None of that's happening. So there's some time to treat that fast heart rate. So it says to attempt vagal maneuvers, and I want to give you some notes on vagal maneuvers. The first one, it's called Valsalva Maneuver. V-A-L-S-A-L-V-A. Valsalva Maneuver. When you bear down, like you're having a hard time, you're constipated, and you're trying to go to the bathroom and you bear down, that can stop about 25% of SVTs. So it doesn't mean you get constipated and tell them to sit on the toilet, but bearing down will increase intrathoracic pressure and terminate about 25% of SVTs. So if you bear down, it increases intrathoracic pressure. And the other one is the carotid sinus massage. Carotid sinus massage. So the carotid artery that you can palpate next to your trachea, massaging that will send an impulse through the vagal nerve to slow down the heart rate. So between the Valsalva maneuver, the carotid sinus massage, it says it'll terminate about 25% of SVTs. I know I gave it to you under Valsalva. So these vagal maneuvers will terminate about 25% of SVTs. All right, then there's a drug, adenosine. Have you heard of this?
Yes.
It slows down the heart rate. So there's two dosages. The first time, it's given IV push because the short life is so short. I think it's, what, 20 seconds or something ridiculously short. So when it's put into the IV, it has to be put in really fast. And, do I have any notes on it? So if the first dosage doesn't work, then a double dosage will be given, 12 milligrams IV push. If that doesn't work, they'll start the patient on beta blockers or calcium channel blockers. All right, so obviously the person has to be stable to give them a chance to take the beta blockers or the calcium channel blockers, monitor them for a few days, see if that helps. And then if the heart rate is still fast, then they're going to need cardioversion. But you've got time to try to solve it with adenosine, with medications. All right, so if they're unstable, unstable means really low blood pressure, poor perfusion to the periphery, altered mental status, low, did I say everything? All right, so you have enough time to give adenosine and see if that'll work, because that just takes a few minutes. If that doesn't work, then they need to be cardioverted. All right, what is cardioversion? It's a low voltage electrical shock applied to the precordium, which depolarizes the entire myocardium. And after you depolarize the myocardium, it'll allow normal impulses to take over. So that's the thought, is you put the pads on or the paddles on the chest, and you'll apply an electrical shock to the thorax, and of course it's going to go through to the heart. And when it depolarizes the entire heart, now the normal conduction system can take over and start generating a normal heart rate. So, does it always work? No. But sometimes it does. It tells you that a cardiac defibrillator is used, and it synchronizes the delivered shock. It has to hit on the R wave of the EKG tracing. So, what's another name for an R wave?
Yeah.
So the QRS complex, or the R wave, same thing. All right, so when the shock is delivered, it has to be synchronized with the monitor. And as soon as the QRS occurs is when the shock gets delivered. Because what happens if they don't synchronize with the R wave and they just apply a shock and it happens here at the end of the T wave? Is that bad? If they apply a shock at that point in time? It's not synchronized? Yeah, but something bad can happen. Defib, yeah, cardiac arrest. So if they just deliver the shock at any time and happens to hit during that relative refractory period of time, now you've got, the heart can pretty much stop, it just starts to quiver or fibrillate, and now you've got a cardiac arrest. So that's why they have to synchronize with the R wave and make sure it's being delivered when the ventricles are depolarizing. The amount of energy that's being used is important to remember, so 50 to 100 joules. All right, so if you're respiratory and they told you that there's a cardioversion occurring and they want you to stand by, and you go to the room, what do you think you want to be preparing for if you're asked to stand by at a cardioversion? Yeah, you're preparing for a possible cardiac arrest. It's possible when they cardiovert and they wait for the normal rhythm to take over, that zero rhythm takes over and you have asystole. Or it could go into defib, which is no heart rate at all. So you're preparing for a code when you're standby. So you said have an ambu bag ready? Yes. So you want to have that out and at the bedside. Anything else? A what?
A stool.
A store?
Stool. A stool, like to stand on?
To do compression.
Okay. Yes.
And mask with ambu, just in case.
A mask on the ambu bag? Flow meter in the wall?
Yeah,
Yes,
connected to the flow meter.
Yeah. And then I see some therapists putting the patient on oxygen ahead of time. I don't know why, but they'll get a nasal cannula out and put it on the patient. Question?
I thought you only shock them when they're in VFib or VTAC.
So why are they shocking at this point in time?
So is this like shocking not in VFib or VTAC when you're cardioverting?
Yes, correct. Yeah, it's just a real fast heart rate, an unstably fast heart rate, and medications are not slowing down the heart. So you'll use a much lower voltage of energy than you would when you're defibrillating for VFib.
Okay.
Yes. It's really painful to get any sort of electrical shock anywhere in your body, including your chest. And patients that have had it, I was watching a cardiac cath, and they put the catheter through to do the cath, and I guess the stimulus in the ventricle caused the heart to go into VTAC. And you see blood pressure going, and they run over, they grab the defibrillator, put the paddles on the chest, and shock the patient. No medication. And I've never seen anybody scream so loud. So it's got to be really painful. So during the cardioversion, since they know they're going to be shocking, they'll sedate them pretty heavily. And that's another reason that airway becomes an issue. Because they'll give them Versed. Versed you learned about? Yeah. And one of the side effects, which is a great effect, is that it causes amnesia. So Verseds on board, they shock them, they scream, but when they wake up, they don't remember it.
Oh, that's a really
Oh.
It's a beautiful thing. The best side effect there could be. All right, so we have two more arrhythmias. The next one is atrial flutter. The atria can actually flutter. You'll see rapidly firing It'll be caused by a rapidly firing ectopic site somewhere in the atria. The atria will depolarize 250 to 350 times per minute, and you'll see flutter waves when you're looking at the EKG. So it'll have like a sawtooth appearance. The AV node does not respond to all of these flutter waves. So it says it's refractory to most of these impulses. So you would see a lot of P waves, but some P waves will go through into the QRS. All right, so here's atrial flutter. One thing on here, so you see P, let me go in between. It says P, P, P. Now I'm telling you that the first wave that you see is actually the T wave, but they're pointing to it as though it's a P wave. So I guess I disagree with the book, but so you see lots of P waves. Does it look like a sawtooth pattern, like you would see sawtooth? What do you? I don't know if you guys have ever seen saws that saw wood.
Yeah.
Yeah.
Saw them.
Yeah. No, like the saws that,
Oh, I saw.
Yeah.
Seen
A
that.
saw that cuts wood.
yeah, it's like very just,
Yeah. Or a serrated edge knife that you cut bread with. Maybe that's a better.
yeah, that's good.
Okay, so it goes up and down, up and down, up and down. So that's what it's saying a sawtooth appearance is. And that's your giveaway that you're looking at atrial flutter. But what about the ventricular rate? It could be slow, normal, or fast. And we're looking at a 6-second period of time. So how fast is the ventricular rate on this tracing?
100?
Yeah, you counted 10 multiplied by 10? Yeah, about 100. All right, it's caused by enlarged atrial tissue, elevated atrial pressures. Why would we have that? Repeat question.
A backup, left-sided heart failure.
Okay, left-sided heart failure
PVR, pulmonary hypertension.
or right heart failure from pulmonary hypertension. Mitral valve disease, cardiomyopathies, COPD. Again, it's the lung disease leads to pulmonary hypertension, which puts a strain on the right heart. Hypoxia, this would be chronic hypoxia. You don't get atrial flutter immediately when you're hypoxic. It would be chronic hypoxia. You could get atrial flutter with exercise and coffee use, alcohol, cigarettes. So anything that stresses the heart can lead to atrial flutter. All right, so that was it with atrial flutter, and now we move to atrial fibrillation. The distinguishing features are that the rhythm is irregular. So I want you to circle that, put some stars next to it. Say no more. Instead of P waves, you're going to see a chaotic baseline. And the reason for atrial fibrillation, there are several irritable areas in the atria that are discharging impulses at a really fast rate, about 350 or more per minute. And it causes the atria to quiver or to fibrillate. Do you know what it means to quiver or to fibrillate?
It's just like,
Yes, like that.
doing anything.
So it's just kind of wobbling a little bit instead of contracting like it's supposed to. It's just quivering. The AV node is refractory to most impulses. What does that mean? Right, it's not responding to most of those impulses.
So the atrial allowed to basically fill, or is it allowed to, is it leave the blood to go to the ventricle, or does it stay alive?
Yes, so there's a little bit of atrial contraction that pushes the blood into the ventricle. Without that nice contraction, there is less blood that gets into the ventricle. But it's not too much to actually interfere with blood pressure. because most of the filling of the ventricle is passive, even though the atrial will contract and push a little more into the ventricle. But the problem is blood kind of stagnates in the atrium and blood clots can start forming. So typically patients that have atrial fibrillation will be put on blood thinners because of that. So instead of the blood moving through the atria to the ventricle and out the ventricle, now it's kind of stagnant in the atria and blood clots can form. All right, it says the ventricular rate may be slow, normal, or fast, and the atrial rate is greater than 350 per minute. So here, it's pretty slow, isn't it? But with atrial fibrillation, it's not always slow. It can be slow, it can be fast. And typically, I don't know if you've felt anybody's pulses, like it feels like it speeds up, and then it slows down, and then it speeds up, and then it's normal, and you're trying to get a pulse. Have you noticed that at all?
Yeah.
Anybody?
With some.
Yeah, it's pretty common with COPD patients. Yeah, so COPD, atrial fib, atrial flutter is common with those patients, again because of the pulmonary hypertension. So when you're looking at the baseline, you don't see nice P waves. Like if I say, is there a P wave before each QRS? You'd say, well, not sure, maybe here's a whole bunch of them, but I'm not sure. So how would you notice you're looking at atrial fib? What you're going to do is look at the distance between your R waves. And when you see that it's irregular, that's going to be your main clue. Your second main clue is that you're not going to see P waves before the QRS. You're going to see a wavy baseline and no nice P waves.
So it's irregular or not there. You won't see it at all.
Right. So irregular P waves, I didn't say that right. Irregular rhythm, and you don't see P waves. All right, so it can be caused by cardiac disorders, COPD, and then certain drugs can cause that. It has Valsalva Maneuver and vomiting under atrial fib. That's interesting.
So vomiting can cause you to go into.
Yeah, that's what it looks like, doesn't it?
Yeah. And then does that mean carotid sinuses?
Yeah, I don't get that.
It's possible that those are like treatment.
Yeah, that's what I'm wondering. But then below it says that hypoxia and hyperthyroidism can cause atrial fib.
Is that true?
Yeah.
Okay, so it's a little typo.
Yeah, so we're going to have to do some research in our textbook to find out why this is listed under causes.